She saw Tropikana.
Okay, we're gonna start soon.
Should be just one more minute and we'll be live on Facebook.
All right. We're ready to go.
And we're live.
All right. Hello, everyone. Welcome to the COVID-19 communityresources.com town hall meeting powered by the Center for Closing the Health Gap. I'm Vice Mayor Jan-Michele Kearney, and I'll be your moderator today, along with superstar Tropikana from 101 The Wiz. And I hear Tropikana move some things around to make sure that she could come, and she is on the way. Now, today, we're actually not talking so much about COVID, but we're talking about caring for our aging loved ones. It's a big topic as our population gets older and our families become multi-generational. We're going to take a look at some of the physical, cognitive, emotional, and social challenges that aging brings. And we're going to share some helpful information. And of course, we're going to answer your questions. So our program today is presented in partnership with the Cincinnati Black Nurse Practitioner Network, Black Women Cultivating Change, Mount St. Joseph University, the Urban League of Greater Southwestern Ohio, and the African American Chamber of Commerce. We have some great partners there. First of all, you know I've got to thank our tech team because nothing happens without them. John Reichel is there, and I think Terrence Daniels is also behind the scenes. And also, I need to remind all of you that we are taping this session so that we can repost it for those who can't be here right at this moment. Of course, you will have a chance to get your questions answered. So if you're on Zoom or Facebook, feel free to go right ahead and start entering your questions, and we will read them after we introduce our distinguished panelists. All right, now to our distinguished panelists. We have Felicia Beckham, nurse practitioner with the Cincinnati Black Nurse Practitioner Network. We have Dr. Anisa Shomo, associate professor of medicine at the University of Cincinnati and a columnist for the Cincinnati Herald. If you've read, Dr. Shomo knows lots of great advice there. And she's actually published nationally across lots of African-American newspapers across the country. And we have Ms. Sandra Curtis, assistant professor of nursing at Mount St. Joseph University. You know, before we get started, let me ask each of our panelists if you could just tell us a little bit about your background. And we'll start with Ms. Curtis.
Hello, everyone, and welcome. Please excuse my voice. I'm losing it because I need to get this information out. But I am Dr. Sandra Curtis. I am a registered nurse. I am board certified in gerontological nursing and an assistant professor of nursing at Mount St. Joseph University. And the amount of honor to be able to educate future nurses and also nurse leaders and nurse educators. In my personal time, I am honored to be able to spread the word about aging and older adults in the Black community. I tend to focus on the Black aging experience, Alzheimer's disease, and end-of-life situations for African Americans. I'm pleased to be here, and I'm glad you're here. This demonstrates your commitment to older adults. And I always have to bring up, as we say at the Mount, Luke 12:48. To whom much is given, much is required. I have been given opportunities of a lifetime, and I'm here to share those with you today. Thank you.
Thank you so much. And Ms. Curtis, we can tell you're making a big sacrifice because you probably need some hot tea and bed rest, but here you are sharing your knowledge. And so just know that we really appreciate you. Thank you so much.
It's my honor.
Yes, thank you. Next, we have Dr. Anisa Shomo.
All right. So I wear a lot of hats, as Jan-Michele mentioned. So that's some of the things, I won't re-mention. I will just talk about my board certification in geriatrics. So I don't tell a lot of people because, there's not enough geriatricians to go around. So I kind of like hide it a little bit. But I am actually a specialist of geriatrics. I did a fellowship at the Christ Hospital, and I worked a lot at Maple Knoll. And so I specialize in taking care of older adults, but I hide it because I take care of all ages. So I don't want people to think I only take care of older adults, but I do specialize in taking care of older adults and aging and Alzheimer's and Parkinson's and all that sort of thing. So I'll have a whole wealth of knowledge that I share sometimes, such as today. I also teach medical students about it. We actually have a geriatrics activity that we do with our medical students. So it's really interesting because one of my students recently said that going through that process actually helped her with taking care of her own grandmother, because there's a lot of doctors who don't even know what to do with their aging parents and grandparents. So it's really, there needs to be a lot more education about how to care for older adults. And that's why I wanted to be on this panel today.
You're right. It's, there aren't that many geriatricians. It's hard to find one. And so I didn't know that was your area. So that's really good to know. Thank you. Thank you for sharing that. Okay, Felicia Beckham, you were able to join us via another vehicle. So thank you so much. I know Ms. Beckham was on earlier and was changing. I think you were changing from your phone to the computer. So thank you so much for being on. So please tell us a little bit about yourself.
Yes, thank you so much for having me. Actually, I started out as an STNA in a nursing home while I was in high school. So Hughes actually kind of spearheaded me towards that path of just healthcare. So as an STNA, I took care of older folks. So I have a different lens on taking care of geriatric patients. I now work at UC, and I also am in the geriatric division. We're around in different nursing homes and rehab centers. So currently work at Maple Knoll and also Bridgeway Point. So really having a different lens on what we can do to help improve on caregiving and also just aging gracefully.
That's great. Thank you so much. Okay, audience, so it's your turn to ask questions. So again, if you're on Zoom or Facebook, you may enter your questions and comments. We'd love to know your name, but if you want to be anonymous, that's okay. So, okay, but we will get to your questions right away. First of all, let me just say just a few facts about aging. The World Health Organization, I didn't know this, the World Health Organization tells us that by 2030, and that's not that far away. This is 2023. So we're talking 7 years from now. So by 2030, 1 in 6 people in the world will be 60 years or older. At this time, the share of the population that's 60 years or older, that means by 2030, the share of the population that's 60 years or older will increase from 1 billion with a B, and that was in 2020, to 1.4 billion. By 2050, the world's population of people 60 years and older will double to 2.1 billion. The number of persons aged 80 years or older is expected to triple between 2020 and 2050 to reach 426 million. So just a lot of folks aging, which is so wonderful. And here in the US, by 2040, about 1 in 5 Americans will be 65 years or older. And that's up from 1 in 8. Back in 2000, that number was 1 in 8. And by 2040, it's going to be 1 in 5 Americans will be 65 years or older. So this is a really good topic. And a lot of us have aging loved ones to care for. So let's just start. I think a good place to start, just if each of you could just weigh in on the question, what are some of the challenges that our aging population is facing? And we can start, you guys can go any order you'd like. If we can start with Dr. Shomo, if you'd like to begin.
Well, I was gonna let Sandra Curtis. So we had a talk before this, and we were talking about like just one of the biggest challenges is a lot of times people don't know what's normal and what's abnormal. And so we were gonna talk about that, like how do you recognize when something is abnormal?
Okay, that's great. All right, so normal versus abnormal aging. Okay, Ms. Curtis. That's a great topic.
Well, often people ask what is normal aging, what is not normal aging or abnormal aging. And that can be hard to determine or to specify. For instance, everyone will age differently based on previous health circumstances, even socioeconomic status and work experiences they've had. But one of the things that's overall fairly common is as a person ages, we tend to see a decrease in function in body systems. For instance, as you age, you may notice, I know I have, a difference in my vision, especially at night. I noticed that there's certain activities that were easier to perform when I was younger. I may have much more stiffness in certain joints or muscles now than I did more than I would when I was younger. However, the changes can be, you can generalize them to the point, but you have to remember everyone will be different. So we have to take that into consideration. But one of the things I do want to say is what is definitely not normal aging, and that is the development of Alzheimer's or senility. People tend to think just because you age, you will automatically develop Alzheimer's or become senile. And that is not true. There's a variety of factors that can play into that developing, but it's not something that once you turn a certain age, okay, you're going to get it. We don't see that. It's based on a lot of factors. And then another thing that people have often commented on is that people become, as you age, you will automatically be incontinent or unable to control your bowel or bladder. That is also not a given. Often incontinence is a result of medications. It may be the result of functional changes within the human body. So just keep in mind, those things are not automatic, but they can occur. But everyone will age at different rates, even though there are common occurrences we see. We can't just rule out everything and say it's because they're old. There are many older adults who function better than me and function better than younger people. So it's an individual experience. There are certain commonalities we see, but each person must be looked at individually before we determine what absolutely is or is not normal aging.
You know, you have said a mouthful. Let me just go back to one part of that, and then we need to look at all the different things you talked about. But you brought up Alzheimer's disease, and so that's scary, right? People are really afraid of that. And if we forget, oh, I walked into this room, what was it I meant to pick up? Oh my God, I'm getting Alzheimer's. What's the difference between, and all of you can weigh in on this, Alzheimer's versus just forgetfulness? Like, when do we start getting concerned about ourselves and our loved ones?
I'll
And
answer.
it's all right
I
to
can answer it.
unmute
Yeah.
and just jump in.
I was just
Unless you're
saying that generally, so there's different types of memory processes. So the two most common memory, dysfunction is vascular dementia. Like somebody may have a stroke or a heart attack and their memory may not be the same after that because they lost, blood supply. So just functional brain, kind of insults to the brain, we call them. So there can be, people can have memory loss after strokes. And so those can look really different. So sometimes people may remember specific things. So those can be a lot more subtle for people to pick up on. Usually a person wouldn't pick up on it themselves. So that's the biggest thing. I tell people, like, if you're worried about having a memory problem, you probably don't have a memory problem, because it's usually other people who are going to pick up on it before you would. People be like, oh, well, they're losing their keys all the time, or they forgot to pay their bills. So it's usually something that somebody else will notice, because people will come in and say, oh, I'm forgetting stuff all the time. It's just like, you got yourself to this appointment fine. you know,
Yeah.
you remember to call and make an appointment. So those are our short-term memory things that a lot of people who have Alzheimer's and Parkinson's can have. And so, but they can all be very, or vascular dementia, we call it. So they can all be very subtle. So it's really up to people to, so I guess I'll get into my piece of, you know, like trying to tease out, like caring for your loved ones, just trying to like pin them down on dates, like ask them things like, do you know what the date is today? Or just making sure you're checking their finances and make sure they're paying bills, because what'll happen is usually people may miss a bill or they may miss a doctor's appointment, that sort of thing, because they can't keep track of the dates. That's a big short-term memory issue. Like in order to remember the dates and your appointments and everything, your short-term memory has to be intact. So you may just, you know, check and see if they're going to their doctor's appointments, look at their medications, look at people's medications in their homes and see the dates on them and see if they have a bunch of the same medicine, that sort of thing. And then the other big thing is go to the doctor with your older adults. So I would say anybody, if you have anyone in your family or anyone you're helping to caregiver for that's over 75, I would definitely say to go to the doctor with them just to make sure that they're doing what they're supposed to do. They are taking their medicines like they're supposed to, just even being able to see the medication list, take their medicines with them to the doctor so the doctor can see if they have duplicates. Because if I see a patient with duplicates, I take the medicine, and we have a pharmacy team. So I take the medicine and give it to the pharmacy team, or I could even just drop them off at the pharmacy and have them destroyed, because you don't want people having a bunch of different medicines, because that can be a reason why somebody may be hospitalized if they get confused. I mean, you may even ask them, like, how are you supposed to take these medicines? And just ask them questions, like a little bit of quizzing of, I call it like snitching. No, you gotta investigate. And you
Good
gotta
snitching. It's good snitching though, right? So you got to snitch to keep people safe.
It's really important, because like my father is 71 and, you know, he's doing fine, but he doesn't always tell exactly what's going on with him. And so my stepmother is, you know, a lot younger than him and understands, like, it's just a different generation. Like a lot of people in that generation can be very prideful and they don't want people in their business and that sort of thing. So that's why I call it that, just a joke. I mean, like, no, I need to know the information. So you know, it's good to kind of go and gather some of this information, go with them to the doctor so that you know what's going on, and so you can all be on the same page, because a lot of times they won't tell you what's going on. And if they're having memory issues, they're not going to remember what's going on either. So if I notice that, I will call the family too and let them know, like, hey, you know, either they're missing appointments or they don't know their medicines. And even our medical, like my medical assistant will, when she goes through people's medicines, she picks up on if people don't know their medicines. And so she'll let me know, and I'll call their family and, you know, try to get the family involved.
And, you know, let me ask you all this, because, you know, one thing, okay, so my aunt was in her 90s and she had Alzheimer's. And one thing I noticed is that her whole personality changed. I mean, it wasn't just that she would ask about her parents, like, are my parents coming to visit, that kind of thing, where you knew, okay, something's definitely wrong here. But she used to be a really outgoing, gregarious person, and she became really quiet. And it's like her whole, everything about her changed. And so is that kind of a sign too? It's not just forgetfulness, like their personalities can change.
Well, often as a person, there are different stages to Alzheimer's. And as the disease progresses, the person will lose more memory. One thing that is key is that as the disease progresses, you will notice a distinct lack of short-term memory. They can tell you what happened on December 1st, 1920 at 2:30 p.m. If you ask them what they had for lunch today, they have no clue. So that's a change in the long-term and short-term. But often the problem of personality changes is quite clear. It does happen. And that becomes very alarming to family members because they're not used to that. I worked one place, we had a lady, she had been previously very quiet and reserved and very kind of strict-laced. And as her disease progressed, she could cuss out the best sailor and make them feel like a child. So that's something that's very discouraging to the family.
Right.
And also along with that, you may see that they start to forget, the person forgets who their family members are. And that can be very disheartening as well. But
Yeah,
a
that's
change in
hurtful.
behavior and remembering family members and loved ones are all problematic as the disease progresses.
Yeah, that can be really hurtful. Ms. Beckham, let me ask you, as a nurse practitioner, what kinds of experiences are you seeing with normal versus abnormal aging?
Absolutely. So the challenge is really like recognizing. We have a lot of the geriatric population that lives alone. So you go in and check on your loved ones only for a hot second, and you don't really recognize the subtle signs. So like hygiene, or making sure that they're actually cleaning their clothes, washing their dishes. All of these subtle things that, you know, we tend to forget. And those are all signs that can really tell us the story to see if that is kind of a sign that they need help, and aging, and needing to, you know, extend different services. Or, you know, is there a sign that something else may be going on? So I would want to make sure that we're always involved in like our family members' lives or caregivers' lives, just because sometimes we miss those signs. If they come out of the house, you don't know what their house looks like. You know, drive with them, see how they are driving, you know, see how they are parking, all of those things. See actually if they remember where they're going. So those are all just subtle signs, and sometimes you just need to just watch and observe. But I think that could be helpful too, to determine if they actually need help.
Yeah, that's interesting. You mentioned hygiene, because I've heard several people mention that they noticed. It's kind of like what Ms. Curtis was saying, how the person was like really, you know, prim and proper, and then they started cussing people out. And with hygiene too, people who, you know, generally look good all the time, and then they kind of show up at church and, you know, like the hem is hanging down, or things that you're going, that doesn't seem like something, you know, Miss Smith would do. You know what I mean? So maybe those are signs we can also look at, those kinds of subtle changes.
Right. Yeah, that's the thing. It is. I was gonna say real quick that what we're talking about, there's actually two names, there's two different categories for them. One is called the instrumental activities of daily living. And so those include cooking, driving, cleaning your home, medication management, using the telephone. Because, you know, so when I teach it to the medical students, we kind of say the things you need to do to go to college, or even like, you know, basically to function independently as a person. So generally things that, you know, a high schooler would be learning. And then the activities of daily living are basic things. We say things that you need to know to go to kindergarten. So grooming yourself, taking a shower, or taking a bath, dressing yourself, feeding yourself. So generally what happens is the instrumental activities of daily living will be affected first. And so that's what we talk about function too. So sometimes people may have a little memory loss, but it's not affecting their function. So, but usually the instrumental activities of daily living will be affected first. Like people may forget to pay their bills, or they may forget what day it is and may not go to the doctor. So that's where we're saying it can be a little subtle, because those are not necessarily things that people do every day. Unless they're like, you know, cooking and burning things on the stove. That's another big thing we haven't talked about. So cooking and burning things on the stove is another way that people may find out that they're having memory trouble. And so usually that's, you know, kind of the things that how people will present if they have people kind of checking in on them on a regular basis. And then later on, people will have issues with activities of daily living, such as they don't know how to feed themselves anymore. They may forget, you know, how to walk. So as people start to lose more of those basic functions that they developed around age 5, those may be reasons why people may go to assisted living or to a nursing home, because they may need people to help them with a lot of that stuff.
Wow.
And one thing we need to really be, I'm sorry, one thing we need to really be
Dr.
mindful
Curtis, go
of.
ahead. I didn't mean to jump in.
Oh, sorry. Many older adults are experts at hiding these deficits. And with the amount of long distance family caregiving, the spread out of the family across different states and even different countries, when we don't have the extended family in the immediate area, family members might not see their loved one for years. And so all that time, this person is steadily declining, and there's no one to really cue that in. And then even if you are in the area, you have to be careful and mindful again that they're very good at hiding things, because they often fear losing their independence. So they hide these things subtly. One thing, I had a patient who could not hear worth anything. And they would just say, and I'm thinking, can't be agreeing with everything I'm saying. But they hit it well. And the family member goes, excuse me, oh, they're so agreeable. Well, they can't hear you. They're just making it up. So we have to look at that. And then also depression is very common in the elderly for a variety of reasons. Often as you age, you have a lot of losses and you don't have recovery time between the losses. So depression, it can easily set in. And depression, even though it's a mental health issue, it can, as it progresses, affect your physiological functions and responses. So we have to watch for a variety of things.
So, okay, that's interesting, Dr. Curtis, about the depression. I hadn't really thought about that because when you're younger and, tragic things happen, they usually don't just keep happening one right after the other. But I guess when you're older and you're losing family and friends who are close to you, it's in pretty rapid succession. And so what kinds of signs do we look for if our loved one might be depressed, to see if our loved one is actually depressed?
Sleeping, loss of appetite, not engaging, not interacting, acting different in regards to just mood changes, not taking their medicines. There are a number of things that could mask depression. So we usually try to make sure there isn't anything acutely going on before we try to dive into depression. There also is like a depression scale that we normally ask everyone that comes in, but there's a specific geriatric depression scale that providers may use in the office. And I think that can help to bring light to how they're actually feeling, because most oftentimes they're in solitude. So that can definitely be depressing as well. And you try to take the things away that they want, like a car and different things like that. And that can definitely exacerbate some depression too.
So here's the thing, and you talk about, depression and being in solitude. And so, we often want our aging loved ones to come live with us, or maybe to live in a nursing home or, a group home or something, but they want to be independent, which means they're going to be by themselves. What do we do in that case? I think, often it's just dangerous to have, older folks living by themselves. They could slip in the tub. I mean, anything could happen. It could happen to, you don't even have to be older for that to happen, right? So
I can speak to this.
Yeah.
Excuse me.
I'm sure we can all speak to it because it's a big topic.
Yeah.
My father moved in with me the year prior to his death. And I remember he lived independently in an apartment. And I remember I made sure that we took at least 3 to 4 months to transition him from his apartment to my home. So we maintained his apartment and we would go over and he'd spend time there. And then we gradually moved him into my home until his death. My mother is still alive, but she lives in another state with my sister. And she was living in my sister's actual home. Well, my mother, who was going on 91, decided she wanted to be independent. So we now have her in an assisted living facility, and she loves it because you can't tell me what to do. You can't watch me. And everybody here is in the same boat, and I don't have to look at you going out. She loves it. She refuses to go back to my sister's home. So we have to allow them independence and support them any way we can in that independence.
Yeah, that's interesting. And so she's happy with the assisted living. And are there ways that people can stay in their home? I know there's some resources like Council on Aging that can bring caregivers in several times a week. Is that something you guys recommend or help with?
Yeah, for sure. Getting the Council on Aging involved sooner rather than later is great. And they also have a program called the Passport Program where people may qualify to be able to get some help with assisted living, because assisted living is a great option, but it can be very expensive for a lot of people. So sometimes people may live in like senior buildings where they have like somebody who can come check on them and they're in an apartment, so less risk of fall, and they try to make them like, American Disabilities Act friendly. So there's a lot of different options depending on people's finances. But I will just say that when you're having these conversations, the biggest thing is people who are rational. So like if somebody is not having memory problems, haven't had any Alzheimer's or strokes, then that is a conversation you can engage with them and not necessarily be like super controlling about, like if they say, I want to go live in assisted living and they're, of sound mind, then that's a great conversation to have. But the problem I have is that people will have like Alzheimer's and they're being very irrational, and their families are trying to rationalize with them, and they don't understand that there is a such thing as elder abuse. A lot of people don't know there's a such thing as elder abuse. So the same phone number that you can call 241 kids about, for child abuse, that's the same phone number for elder abuse. And so in Hamilton County, yes, in Hamilton County, people 60 and up, you can call if you're worried about, because there's a such thing as self-neglect. Like if they neglect themselves, you can call, because that's a way to get them involved with Council on Aging. So usually Council on Aging will kind of prioritize them and get them on the list. And then that can help families as well. But a lot of times people just let people just kind of do whatever they want to do. And it's just like, that's neglect and that's illegal. And a lot of people don't realize that older adults are protected population, and that we pay tax dollars to try to help support them and all that sort of thing. So that's the biggest thing. It's just like, if people are being irrational and they're neglecting themselves and they don't, then I probably call elder abuse on people a couple times a year. It doesn't happen that often because most families are doing great and try to be reasonable with people, but it's just hard when some people are being unreasonable and irrational, and people are like, I don't know what to do. And I usually like call elder abuse so that they know that they can't just sit in their house and be irrational and not take care of themselves. So, there's different options to help people understand how serious it is, because a lot of times people are just like, I don't know, this is what they want to do. And it's just like, that's illegal. They can't just make those kind of decisions for themselves if they can't care for themselves,
Now, Dr. Shomo, are you calling on the family, or you're calling on behalf of the elderly person?
That was my question.
Like,
it depends.
Who's in trouble?
Yeah.
It's usually not about anybody being in trouble. It's just generally about supporting older adults. And so often it's usually me calling on the patient because their family's trying to help them and the patient will not accept their help. So that's usually what it is, more of that kind of thing. But every once in a while it is the family is, sometimes it's the finances. So there's a such thing as financial abuse. So I talk to my students about, there's physical abuse, there's sexual abuse that happens with older people, there's financial abuse. So people may just be going to visit their family and taking their money. So I've called usually for that reason on the family. If they're just going to see them and taking their money, then I will, we're actually required to report. It's the law. So a lot of people don't realize that. And obviously I don't want anybody to not come and see us and that sort of thing for that reason, but we're just here to do our job. And if we see anything like that going on, then that's our duty to report it, just like with anything, like I said, with special populations, such as, people who have disabilities, people with young children, older adults are a special population. So, like I said, it doesn't happen often that I have to call, but every once in a while, if people are, if it's, and it's usually like I said, it's usually for older adults who are just like, no, they're being very stubborn, and their family's like, I don't know what to do. And I'm just like, okay, I tell the family, I'm like, okay, I'm going to call elder abuse and get a social worker in there and figure out how to resolve this, because there needs to be a mediation.
Right.
Now, Dr. Shomo, when we talk about elder abuse and calling 241 kids on our parents, tell me what are the things that we're looking for? What type of signs should I be looking for if I need to call? Aside from maybe a parent or a loved one acting irrational, what are other reasons that I would call the elderly abuse?
Well, when I'm saying irrational, I mean that they're not safe to be in their home, but they refuse to do anything about it. So like they're falling and they can't reach a phone, and they're gonna fall and break a hip and be on the floor, and die that way. So so say for example, they fall and there's some kind of like near miss where something really tragic could happen. They're like, you're not safe to be in your home anymore. And they're like, no, I'm going to die in this house. That's when I would consider calling elder abuse, because that's not a rational response to that kind of situation. Because, people just, they're like, I'm going to be fine. And it's just like, you're not doing fine. So, and the other big thing would be like if somebody's losing weight because they're not eating. So sometimes that's a big thing, a big sign is that people may not be able to feed themselves. They may not remember to eat. And so you're trying to help them, you're trying to get them to eat, and they're like, no, I'm fine. I don't need your help. Get out of my house. So that's one of the patients I had to call elder abuse about. They're moving away. They weren't eating. They didn't want any help. So I told their daughter, I'm going to call your, I didn't tell the patient, but actually that patient loves me for doing that. So that's the thing. Like, people think that, you call elder abuse, they're going to be mad at you. I don't know if he knows that I call elder abuse. All he knows is the Council on Aging came and they gave him Meals on Wheels and he has food all the time now. You know, so that's the biggest thing. A lot of times people think it's this contentious thing, but it's for me, like, it's just a way to get mediation. Like, there's a problem, this older adult is neglecting themselves in some way, and there's some kind of safety issue. And so you call them really to address the safety concern. And so the Council on Aging is very good at coming in, addressing that safety concern, leaving a lot of the other drama.
Right. Yeah, because there can be a lot of drama.
Yeah, exactly.
Yeah.
But there's no rule book, like when you have a baby, there's no kind of book to use. And also as a caregiver, there's no book. So we're kind of just, going off of what we know mom and dad to be and what they are, and not transitioning to this older adult and how to take care of them. So sometimes there's challenges and also negotiating or reasoning or the appropriate thing to do for mom and dad. You just want them happy, but also safety is a priority. So we have to kind of have that tug and pull. But also, as a caregiver, it can definitely be stressful because you're trying to manage your life. And now you have, mom and dad to manage properly and safely, and you just don't know how. So sometimes that can be a lot within itself, especially as you're trying to navigate through things too.
Yeah, I was going to say too, that we can talk about legal things. That could be a whole nother program, but just so people know, sometimes you have to go to court and have a loved one appointed a guardian of the person who's aging because they aren't handling their finances correctly. And sometimes if there's no family member who could be appointed a guardian, the court will appoint a guardian so that, some of the things Dr. Shomo mentioned about, people having their money stolen and their finances mismanaged and bills not being paid, but to have a guardian appointed by the court to actually do that for the person. So they step in and become their legal entity, really. And so that's something else, but that's in the whole nother story, and sometimes a lot of drama there too. So speaking of drama, let's talk about what do we do? So now we're at the point. We've talked about normal versus abnormal aging. So we've noticed with our loved ones that the signs that you all are talking about of abnormal aging are there. They seem depressed. They're not eating. They're not paying bills. Their hygiene is poor. They're starting to, cuss people out when they really you never heard them curse before. I mean, things are changing. When do you have that conversation, and how? I guess how is more the point, because people want to be independent, so how do we
I could never have that conversation. She's going to tell me I earned this right. I live my life this long to talk to people however I want to. So how do we know the difference between this is your right as my elder to say whatever you want because you live this life, and no, you got to go? How do we know the difference?
Right.
I think a lot of it becomes, for me, the crossing line is when your older adult safety is at risk, their safety and health, and even their life is at risk. I know I had to talk with my parents, and it was kind of easy, but it wasn't. My dad was retired military and a pastor. I wouldn't tell him anything. He told me what to do.
Right.
My mom, well, she's just my mom. She tells everything. I think she told God what to do last week. But recognizing that at some point, you have to move beyond the role of maybe adult child and think more of it. And I hate to say this, but of a parent child or a protective position, and bite the bullet and have that conversation. The key is to have it as early as possible while the person still has the majority of their faculties and can participate. And also you want to approach them in a non-threatening manner. You can't bring the whole family in on the holiday and say, okay, we ate dinner. No, we got to talk about where you're going when you start acting crazy. That's not going to work. They're going to bite the bullet and hold back more. Just like a kid, I have all grown children, but some of their partners they picked out I didn't like, but I couldn't tell them I don't like him or her. I had to kind of let it play out. So they thought they were making a decision when really I was behind the scenes maneuvering. So we have to do that with our aging parents as well. So start early. Make it so that it's not a conversation of dread, but let them know you're doing this in their best interest. And then also consider, excuse me, that a lot of older adults don't want to talk about it because again, it hampers on them losing their independence. And also I found that a lot of parents don't want to talk about it because they feel like it burdens their children. and they want to stress their children out. So I've made my arrangements. I know where I'm going when I get crazy. I told the kids, don't come visit me, just leave me alone, because I don't know who you are anyway. And that's
Oh, Dr. Curtis, that's kind of severe. I don't know.
No, but it's children want to take care of their parents. The parents don't want to become a burden, and they also don't want to give up their independence. So it's a very delicate conversation. Start it, make sure that the older adult is the center of the conversation, and they're allowed to have some control over it. But you have to get that conversation done.
Yeah, and when it is kind of like later before when people are kind of like borderline, it's good to partner with your doctor. So I'm sure people are like, I don't want to go to Dr. Shomo, she's gonna call it elder abuse. I don't call them often. I obviously try to work with the family first. I try to work with the family first and, try to do everything we can do to troubleshoot. Because that's honestly why I love being a geriatrician. It's a lot of problem solving. It's like playing chess like all day. Like, how can we fit this piece of puzzle together and that sort of thing. And most families are really amazing at making it work. I'm just saying that like, it's a difference between when you have an irrational conversation with somebody who can, be a part of making that chess puzzle pieces together versus I just get frustrated when people are letting people who are, like can't drive. Like I had a patient who I told them not to drive anymore. And, the family's trying to argue with her. And I'm just like, just make the car disappear,
Really?
But that particular family asked me to report her to the BMB because they were like, she will not listen to us. Please report her and take it out of our hands, so they, so you partner with your doctor. And we always say, let us be the bad guy because we're not at home with you. So if you come to us and you're like, I really like want to get her to stop driving, can you please tell her to stop driving? Usually most people will listen to us. And then, like I said, and if they don't listen to us, then there's other, routes. And so you can report people to BMV, that sort of thing. So, it's just different ways to problem solve. Those are the extreme ways that, things may have to happen, but most of the time you don't end up there. Like usually if like, for example, I have like a couple of 90-year-old patients. One of them came to the doctor's office by herself once and she had missed a few appointments. And I said, where is your family? And she was like, I don't want anybody in my business. And I was like, people have to be in your business. Please go get your family, And so, she was like, okay, great. People, your doctor says somebody has to come with you to your appointments now. And so that's so that, it doesn't have to be an argument with the family. Like, I want to know what's going on with you. I demanded it. I said, no, you're not coming to your appointment. You need to have your family involved because that's part of it for me is I have to know that people are taking care of you. So it's just one of those things where it kind of, we work together as a team to try to figure out how to support people and not have to go those extreme routes. But those extreme routes are there if you need them,
I'm glad you brought up about taking the keys because that was another question, how do you have that conversation and how do you know when it's time to actually take the keys? And I was going to say I had a relative that, we thought the driving was pretty bad. And also she was getting lost going to places she usually went to. And so her doctor said, take the keys. And she was there. And then she had to have a driving test, which I think at first she failed. There's certain things you have to do, like you step on pedals and they test your reaction time. And then she ended up taking a test and passed it. So unfortunately got her keys back. She never had an accident, luckily, but well, no, she did actually have an accident. That's right. I take that back. She ended up totaling her car. She wasn't hurt though. So that did away with the car. But I'm just saying, how do you know when it's time to actually take the keys?
And the biggest thing also is to know like why they want to drive. So why they're interested in driving. Some people, of course, it's independence, or it's because they want to go see their friends, or they don't want to be a burden to the family. Or they just want to hang out, and go to the mall by themselves. So just try and think about why they're interested in driving, and then be creative. Hey, I can get you someone on Mondays to take you, to so-and-so, or hey, how about your friends come to your house versus you go to them. So really just kind of dig deep and figure out and just be patient with them, because sometimes it's kind of a tug and war, but kind of think about the reasons why they want to do the things that they know is not safe for them to do first.
Right. And then I guess, approaching someone about taking the keys, that's hard. And maybe that's just like the other conversation we were talking about when it's time to actually get help. But
And- and
that's a
couple-
hard conversation.
Adding to what you're saying, Jan-Michele, I am curious as to how to have that conversation as well. When you have people at the BMV that are assisting elderly people take their test, like you said, I have a friend whose grandfather, I think, turned 83 last year, and he went to the BMV and they helped him take the eye test and they helped him pass all the tests, and he's outside driving today. So, and of course, the family all is saying, where are you going and why do you need to go there and sit down somewhere? But how do you initiate those conversations when the BMV is allowing and helping them pass these tests?
Yeah, they're trying to be helpful, but it's really not.
It's
Yeah,
not.
That's hard.
Can anybody speak to that? How y'all gonna tell y'all mom?
Well, I don't, that's what I'm saying. I don't usually, so what we do, it just depends on what's going on. So if somebody doesn't have like memory trouble and that sort of thing, and I don't have like a diagnosis to take it away, like if somebody has Alzheimer's and I have a diagnosis that their short-term memory and their attention span and all that sort of thing are not doing well, then I can tell the family, like, get rid of the car, take away the car, and I usually write a prescription that says no driving, so that when they get home, they can say, see, remember Dr. Shomo said you can't drive. Oh, remember your car's gone because we don't, we got rid of the car. But if somebody doesn't have any memory trouble and they're like, sometimes people get like arthritis in their neck and that sort of thing and they can't turn. So for any other reason that somebody is having an issue, you could, if somebody's going to the BMV and they're getting help, that's usually like a routine kind of thing. But anybody can actually report anybody to the BMV and say you have concerns about their driving. So if you have concerns about their driving, so I don't know about your experience, Jan-Michele, as far as, when they went and then they did because there's a couple of different ways that they do the driving evaluation. One of them is done off the road, like a simulator.
It was off the road. Yeah, the first one was
Yeah.
off the road.
It simulates like reaction time and that sort of thing.
How
and
fast they
then-
hit the pedal, are they using the right feet? And the thing you're saying about the neck, how far, how can they see, from side to side, turn from side to side, that kind of thing.
Right. Yeah. So then so that's part of it. And then usually if they pass that, then they can go to the driving part. So I don't know how that person got through because they usually shouldn't be able to try to
Yeah,
do
she actually failed that part. And then,
yeah, exactly. So if they fail that part, they shouldn't be allowed to do the on driving test. So that seems like an anomaly. Usually if you fail that part, you can't do the on the road test.
yeah.
But yeah,
Vice Mayor, you need to call elder abuse on the BMV to help them.
Oh,
You're gonna have to call the number.
that's right, Dr. Shomo, you're gonna have to do that. But it's good. So let me ask you this too about, because we're kind of running, we're getting short on time, but I wanted to ask about living situations. And does anyone have recommendations for, is assisted living better? Is it better for elderly people to stay in their home? How do we help make those decisions?
Yeah, it depends on functionality. So your highest level of functioning patients, meaning that they're able to drive, they're still able to cook, they're still able to feed themselves, they're still able to make decisions for themselves. Independent living is a great place to live, meaning that they're in their own apartment, but they don't have to worry about grass, they don't have to worry about any kind of ancillary things. Now, if for some reason they need a little bit of help with taking their medications or reminders like that, assisted living is the one below the independent living. And that is still an apartment style setup. And then also, I'm not sure, I think they still can they still cook or not in assisted living?
Often they will have modified kitchen arrangements. It depends on the facility. They may be in a facility which the individual units may have a microwave, but not an actual stove top.
Yes.
So that might be the issue there.
And then
once, if for some reason they decline in regards to mobility or forgetfulness, increased falls, a risk to themselves in regards to safety, then they would move over to a long-term care unit where they have 24-hour care of everything, meaning that they need care with all of their ADLs in regards to cleaning, bathing, washing themselves, feeding, all those things that they need a higher level of care. So it just really depends on their functionality to determine where you would consider placement.
Now,
And I-
Dr. Shomo, and actually everyone on the panel, can I ask a quick question? I know I joined the conversation a few minutes late, but I was really curious as to short-term memory loss. And I know you guys talked about abnormal and normal aging. With our parents, when they get into these places where they are a little forgetful on a day-to-day basis and it scares them, if it's not coupled with other things, should they be concerned? When should they start talking to their primary care physicians about if there are things that need to be checked out? Is memory loss or short-term memory loss enough?
With that, you also have to consider, excuse me, are there other issues going on in that body? Medications can cause short-term memory loss, can affect their memory. So you have to look at the whole picture. Is this something new? Is it something huge that just started? Or has this been slowly progressing? So there's a variety of things to consider. But if the person is feeling uncomfortable about their memory loss, by all means, they need to discuss it with their caregiver or their family. And that's something that should be brought up at their very next appointment with their primary care. And if it's to the point where they're actually afraid, then maybe that's a call to their primary care and say, hey, we need to get in a little bit earlier. This is going on. But it's, again, it's very individualized. But if it's an overwhelming concern, absolutely. It needs to be brought up to the primary care as soon as possible.
Another thing, I'm glad you said that. Another thing that I have just found an experience with older relatives is sometimes when they act a little loopy, it's because they have urinary tract infections. I mean, UTIs. I don't know if anyone else has found that, but I've seen that several times, and I don't know if that's like a thing in medicine.
Right. That's called delirium. So that's one of the things we talk to when we do this lecture. We tell them the difference between delirium and dementia. So if somebody has an acute change, like they're all out of nowhere and just started acting weird, then usually you try to figure out why. So you do a full workup, because stroke can be a reason why people may be delirious. Like strokes and heart attacks are another reason, because they're not getting oxygen to the brain, So there's a lot of different reasons why people may all of a sudden become confused. A new medication is another reason why people or they may have taken their medication wrong. Sometimes their blood sugar can be really low, like maybe they're on too much diabetes medicine. So there can be a lot of reasons why somebody may have an acute change like that. So generally, if they have an acute change, generally you should be, taking them to the hospital to see what's going on with that. But as far as just like some of the subtle things where they're just like, I feel a little bit foggy, then that can be a primary care visit to just see if there's any new medicines or if there's, just something different. Like I said, they're not eating enough, because sometimes people just don't eat enough and their sugars are getting low. So there can be a lot of reasons why that could be going on. But Tropikana, earlier when we were on here, we were just talking about like how usually, so the classic thing where people will say is like, oh, it takes me a while to remember things. And so that's pretty normal. Like for me, I'm almost 40 years old, and there's just times when it takes me a while to be like, what was the name of that thing? What was the name of that thing? And then like an hour later, you remember, oh yeah, that was the name of that thing. But for people who have short-term memory loss, they won't even remember that they were trying to think of it. Like say, for example, somebody was like, oh, did you ever remember that thing? And they'll be like, what are you talking about? So that's kind of like, it's very subtle. But normal aging is like, we say it's like a file cabinet. There's a lot of files, and it takes more time to access the files. But for people who are having, either stroke memory loss or Parkinson's memory loss, and the other big thing is Parkinson's, the hallmark sign is hallucinations. So I had a patient who had Lewy body once, and she was saying things that she actually ran out of her house and in the cold at like 30-degree weather, and the police found her. And she ended up going to live with her son after that because she was frightened, So you may even ask your loved ones, like, do you ever see things that maybe frighten you or anything like that? So because Alzheimer's and vascular dementia can be very subtle in a similar way, where people have subtle changes, but Parkinson's is a little bit different in the way it presents. And people with Parkinson's, it's like a whole other thing. Like they usually lose like loss of face expression. They may fall a lot early on because it's like a movement disorder where they get kind of frozen. So there can be a lot of different reasons. So if you notice people are having a lot of falls, we ask our older adults every time they come for their physicals, have you had any falls? So, there's a lot of different things that you look for to figure out if there's any kind of abnormal process going on.
And also thinking about it too is that our grandmas are, 70, 80 years old, and they have 70, 80 years worth of memory. So can you really expect them to remember everything? So just kind of just be, have a little grace with them sometimes. Because my sister's like, do you remember them from high school? I was like, no, I don't remember them from high school. And it's like, so for me, it's just like, I don't remember everything.
Right.
But, just kind of give them some grace too.
Right. Like, especially, like I said, if it's affecting our function, like they're burning things on the stove or burning things in the microwave or getting lost or,
And those kind of things are still kind of hard to sometimes pinpoint,
Right.
when we're looking at our parents, like my mother. She is going to pray away every memory that she forgets. I forgot that. God, just hold my memory, God, bring it back to my remembrance. Or if she has an accident, I can't tell if this is something I need to keep an eye on or if you're just clumsy, because clumsy runs in our family. It's in our genes. So kind of being able to tell the difference between the two. I'm glad we had this conversation because it's absolutely very necessary.
Absolutely.
Keep an eye on it.
Ask the date. Yeah, keep an eye on it, but ask things like the dates and check the bills. Like, are the bills being paid, on time? And, do they know the date? Are they missing doctor's appointments? So for me, those are kind of some of the first signs of like people missing doctor's appointments, people forgetting to pay bills, those sort of things.
That's, you guys all have such good advice. So as we close, before we get to Ms. Renee Mahaffey Harris, our fearless leader at the Center for Closing the Health Gap, let me ask each of you to give us just a final, 1 or 2 minutes, things you want to make sure our audience remembers, whether it's some kind of resource or just something you want to make sure is a takeaway from this conversation. So let me start with Dr. Curtis.
Well, thank you. The big takeaway for me is everybody's different. We're all individuals from the time we're born, so we shouldn't all be the same as we approach older adulthood. So we're going to be different. Pay attention to what's going on, honor the older adults' wishes, and include them in all activities related to their health care and their lives. And just like Felicia was saying, you let them have some grace. You don't want to be disrespected. They don't want to be disrespected. Everything's going to be different, but we're in this together as a family. And then the other big thing is take care of yourself. Caregivers often will die prior to the care recipients. So take care of yourself, but know that this living, dying, aging, it's all part of the human experience. And we're okay with that. We need to take care of each other with grace, with love, and with patience.
All right, thank you so much. Ms. Beckham? Ms. Beckham, can you hear me? There, Ms. Beckham, okay, she might be frozen. Are you, Ms. Beckham?
Oh,
Sorry.
Okay.
I would encourage everyone to really identify and figure out if they're actually a caregiver, and to know that there's resources out there. Closing the Health Gap has a great session, actually instrument that they can use to help to support them in this role, and also help to support their loved one in this transition of time too. So just to recognize that there are resources out there, and that we're here to help.
That's fantastic. Thank you so much. All right, well, Dr. Shomo knows.
Well, I guess the two things for me would just be to look up the instrumental activities of daily living. I don't know if we have them on the website, but we should get that on the website, because that will help you monitor people's function. So the instrumental activities of daily living and the activities of daily living need to be, keep an eye on that for your loved ones that you're caring for. And just let us know, just be in communication with us and let us know your concern, because there's been so many times when I've had people be like, oh, I knew their memory was having some issues, but I didn't know what to do about it. Like, call their doctor, let them know that you're worried about their memory, go with them to the doctor. And like I said, even if you're not worried about their memory, once they get a certain age, like over 75 especially, go with them to the doctor. It depends on how your family is, because everybody's aging is different. So my father has been chronically ill for a long time. So my stepmother goes with him to the doctor way before that, probably since he was 60. So it just depends on your loved ones, what they have going on, but definitely as they're getting over, 75, because that's a really high risk age, because people start to lose weight a lot. They're not eating as much as they should, and they may be falling and that sort of stuff. So that's the age where you definitely want to make sure that you're going to the doctor with your older loved ones.
That's great. Okay, we're going to turn it over to Tropikana.
Thank you, Vice Mayor Jan-Michele and Kearney, the people's champ. We love you so much.
We
I
love
can't wait to get to
you.
these town halls to tell you that you are the one, and we love you. Also, Dr. Shomo, your transparency and your very upfront and honest conversation every time is so appreciated. You make it so relatable for us to ask these questions, because Dr. Shomo knows, and we appreciate you. Also, Dr. Curtis, thank you as well for providing your resources and your information. And then you, Ms. Beckham, you as well. On behalf of the Center for Closing the Health Gap, I do want to remind you that Hamilton County has teamed up with the Center for Closing the Health Gap to present the Caring for Your Loved Ones initiative. It's a very amazing program. If you are taking care of a loved one, or maybe you know someone, this is a great place to find those resources that you need to be able to adequately do that, as well as not feel guilty or get your questions answered, or whatever resources you need. You can call 513-585-9879. That's 585-9879, and reach out to the Center for Closing the Health Gap and ask and inquire about the Caring for Your Loved Ones program, so that you can get your loved ones and yourself the help that you need. Thank you, ladies, for joining us on this panel. Thank you to everyone who tuned in, and we cannot wait to do this again with you on our next town hall. You guys have a wonderful and blessed evening.
Thanks, everybody.
Good
Thank you for
night.
having us. Bye.
Thank you. Great panelists. Thanks.